Call the meeting to order. I'm going to turn it over to Michael.
Hi. Yeah, that would be fine. Hello, everyone. Thank you. So it is time for our, I'm assuming we're doing annual review, correct?
Mm-hmm.
Perfect. For 2022 with CDPHP. So at this point, I will turn it over to CDPHP. Okay. Thanks.
Okay, great. Thank you. I will start. I think we'll just need to do some introductions since there are a lot of people on the phone and then also in the room. So I will begin. My name is Erin Vickers with CDPHP, and I'm the account manager responsible for Columbia County. Also on the line from CDPHP, we have Lori Lincoln, who is our Senior Vice President of Pharmaceutical Care Programs. We have Diane Purcell as the client manager responsible for Columbia County. Amanda Neaton, who is our supervisor of care management. And Heather Mahako, who is the outpatient care manager specifically for our self-funded clients. And then in the room, you have from CDPHP, who you probably have already met, Patty Scott, our Vice President for Commercial Growth, and Tamara Marziani, our Manager of Alternate Funding.
You want to go around the county quick?
Kelly Vaccaro, Clerk of the Board.
Rob Lagonia, Town Supervisor in Austerlitz.
Matt Morrell, Chairman of the Board.
Jim Bragg, County Controller.
Michael Reardon, HR Director. Board of Health Study HR.
Steve Acciani, Broker.
Betsy Acciani was the broker.
Brenda Adams, Canaan Supervisor. Nice to meet you. Thank you. All right. And Art's on the.
Art, oh yes, Art Basson.
Art Basson, Ancrum Supervisor on video.
Okay. Is that everybody?
That's everybody.
Okay. Can you see my screen okay? It looks like I'm presenting, but
Yes.
Yes.
okay.
You're good.
Okay, great. So to begin, we're going to have a brief corporate update given by Patty, and then I'll walk through the 2022 data summary, really like a high-level review. Obviously, if any questions come up throughout, please shout out. We'll have a pharmacy update from Lori, and then we'll talk through opportunities and any other questions or discussion items that you'd like to cover. So with that, I will pass it on to Patty.
Thanks, Darren. So I'll keep the update brief because I know we really want to dig into the data here. Thank you for having us all on site and virtual today. And so just a little bit more about where we've gone in 23 and where we're headed in 24 is really just to continue to focus on total cost of care. So the goal is to drive costs down, as we all know, ensure easy access and transparency in our integrated model. So to continue to integrate, to ensure that we are having appropriate services rendered in the appropriate care model, and then quality over quantity, of course, is the core of all things surrounding our members. And so we're going to continue to endeavor on that and pivot where needed to ensure that all of the members are having the highest quality of care in the most appropriate place at the lowest cost possible. And with that, I'm going to turn it back to you, Erin.
Okay, great. Thank you. Any questions or discussion for Patty before I begin the 2022 review? Okay. So to begin, we have a demographics and paid trend overview. From a demographics perspective, we can see overall membership decreased 5.6%. The larger decrease was on the dependent side with 7% from the prior period and 3.5% on the subscriber side. If you jump over to the graph on the right, you can see there are decreases in outpatient and professional spend, and then quite a significant increase on the inpatient side. The paid PM trend is up 15.5% from the prior period, totaling 509.24. Now, that being said, that large jump is due to a single claimant that totaled $1.2 million in spend. Much of that spend also went into the inpatient category. So to give a more accurate picture of really how the plan performed outside of the one high cost claimant, we removed that high cost claimant from the picture just to calculate what the spend would have been. And that paid PMPM trend went down to 437.08, which is just slightly under the prior period. So while obviously spend did go up, this is a positive thing to see that, the medical member paid trend did go down just a bit, with the exception of this, very large claimant influencing the inpatient spend and then spend across the board. The inpatient increase was mostly in the surgical category from the high cost claimant. It almost doubled, went from 477 to 986. Also, a few of the high cost claimants in the top 10 category contributed to that spend as well. When you look at the outpatient category, you see it's down. The largest contributor to that decrease was a high cost claimant contributing to outpatient pharmacy spend. So that outpatient pharmacy category was down a little over 200,000, which is why you're seeing a decrease there. Now, I just said a lot, so I'll pause to see if there's questions on what I just covered.
Aaron, the $1.2 million claim was partially reimbursed by stop loss, right?
Yes. So I actually have, I didn't include that slide in my deck, but I have a detailed breakdown of stop loss that I can provide after the meeting.
Just saying that out loud because 1.2 is a shocking number, but if you
It
were
is.
reimbursed by stop loss, it closes the gap quite a bit.
Yes. Okay, so what's not listed here are some of the other cost drivers under the clinical conditions category. So I'm just going to talk through a few of those. The top cost driver was diseases of the digestive system. And those are really all attributed to our high cost claimant of the 1.2, in addition to one other. And outside of the high cost claimants, we saw some of the more pricey condition categories were musculoskeletal. So, things like arthritis and joint disorders, circulatory disorders like heart disease, hypertensive, and then nervous system disorders. And lastly, factors influencing health status. So those are your office and specialist visits, maternity visits, preventive care. So those are the ones that had some of the highest utilization categories and also highest spend. So next we have utilization for ER and urgent care. So we can see that ER increased while urgent care decreased. About 6% of the urgent care utilizers from 2021 went strictly to the ER in 2022. So that equated to around 40 people. And that had an additional paid amount of almost $40,000 over the prior year's urgent care costs. So that's just to say ER, of course, incurs greater cost. I noticed that. Oh, sorry.
Urgent care. I do believe locally the urgent cares were closing earlier, not opening as early in the morning. So I think that change might have helped.
Yeah, I wrote down for that to be an education point for us because remember we had problems with repeat offenders in the emergency room that were going a lot. You're talking, all we have to do is kind of reintroduce the why would you want to pay a $50 copay when you can pay a $25 one. We don't need to get into the fact that it's better for the county, but we definitely were able to work on that before. So we'll make sure that's one of the front things on our next newsletter.
That's great. And we can also help with that. And that was exactly what I was going to say next. Both of those things. So I was going to ask you if maybe there have been some urgent care closures in the area potentially, but changing of hours, that can certainly influence something like this. And then education and reminders are always helpful. I did notice that a lot of the claims were injuries, like there were a significant amount of injuries. So most of those should have gone to the ER. But then there were also plenty of non-emergent visits that were under the category of like general symptoms and signs. So headache, cough, cold, flu. don't need to be going to the ER for that. So education, definitely a great idea, and we'd be happy to help spread the word on your behalf.
Yeah, in the newsletter, we can probably include, there are a lot of urgent cares now that weren't normally considered, like, so I do see there, some of them are going to Albany and St. Peter's.
Right.
So you have a lot of your orthopedics now have urgent care hours. I know Albany ENT and Allergy has urgent care hours. Capital Cardiology Associates, even instead of going to the ER, if you're kind of feeling something, they have treatment right at their offices now with like an urgent care type facility. So
maybe
probably
we could
include
even
some of that.
pull those and do a little posting on the front of, did you know?
Yeah.
Did you know
Yes.
that this place has this? Because like when Bone and Joint opened up that ortho part, it really saves a lot of
Yeah.
time and certainly less of a copay. So great,
Yeah.
thank you.
Okay, when somebody walks into the ER, and I ask this because we've seen examples of it, here in Columbia Memorial, are they necessarily charged ER rates? It seems to me that we've had some urgent care charges instead of emergency room charges. Is that possible, or am I imagining?
I think, it could depend on who the hospital is and who their affiliates are.
Right.
So there are some where they have kind of they'll evaluate you right when you walk through the door, and they'll kind of either, you need this level of care or you need this level of care. So I think at the end of the day, it's how they're billing.
Okay. We don't know about these guys, right?
Also, I'm sorry, finish this.
No, I was just wondering, for a while there, I was seeing emergency room visits being charged as urgent care, and they come in a little bit less, not a lot less.
A specific hospital or
Yeah,
all
up here,
over? Here, okay, we can find out.
It would be nice if they didn't hit us with a emergency room care if it's only the flu or something, yeah.
Yeah.
I'm sorry.
No, I was just gonna say to Michael, the other thing about that is, I mean, I went to urgent care and had 2 broken bones last year, and they said, well, you have to wait till Monday to go get an X-ray. If you go to somebody that has those hours open, you can get taken care of then. So it means that they get taken care of much more quickly.
Yeah, the Albany one in Coxsackie has they actually set my son's arm right there. And then when I went to, they didn't even take the cast off because they had already had it all done. So yeah, you're absolutely
So
right.
Bone and Joint has an urgent care, so does, Ortho New York has it.
Yep.
Yeah, fantastic. So
But regular doctors are telling you to go to those because regular doctors are so backed up. You can't get in with an orthopedist for 2 months.
yeah.
So everybody runs into these places.
Yeah.
We just
Because
want them away from, the
The main ER, the
I think
hospitals, yeah,
there's-
you want them to go to these urgent cares.
Good opportunity for us to partner on some flatter, like, did you know Bone and Joint has?
Exactly.
So I'm sorry, the urgent care is how much of the copay?
21.
What's that?
25.
25
And ER?
Compared to 50.
But you can see, like, for Albany Med, 45 visits for urgent care, but was $6,400 versus 30 visits was $66,000 at the emergency room. So we want to just keep pushing
Big
people
difference,
to
yeah.
urgent cares.
Well, the big issue is wait time, isn't it?
Well, and some could be under.
Well, yeah, it's cost and wait time. I mean, you're there for 24 hours, and you're
Right.
lucky you're seen, you're still sitting.
Well, like
Chair
Mary
in the
said, they
hallway.
test you for everything. You get tested for stuff that isn't necessarily even a part of what's going on. So yeah, that's why you end up there a long time. And they're going to take emergency people. So unless you've got, stab wound in there, you're going to wait.
We are working on some creative things like treatment in place.
Yeah, I didn't know if I should mention that.
I think you should.
Because I don't have all the details for self-funded and how that all works. but-
It's, so I guess in
It's
summary,
24.
we see this a lot happening, right? The world's
Not
returning to normal and people are still all jumbled on where to go and when to go and appropriate site of care. We've seen the trend in ER go up, and to address that, we're exploring a treatment in place option. Again, not fully baked, not priced for ASO. We don't really know how.
We're finalizing our contract, but the hope is what we're filing it for is to roll it out for 2024.
What is
And
it?
so it'll be a couple things. So we refer to it as treatment in place, but it's with United Concierge Medicine. And so you call an ambulance at the time of ambulance arriving at a home, instead of just putting them in and charting them off to the ER, right? Which now you have the ambulance, you have the ER, and then whatever extra fee they charge if you come through that ambulance door. They will have an iPad with them that connects to the physicians at United Concierge Medicine, and they will triage them right there and determine, do we need to schedule you with your provider? Do we need to schedule a follow-up for something else? Do you truly need to go to the ER? And of course, they're immediately going to do that, but it hopefully will be a lot of cost avoidance and just redirecting people to the appropriate site of care.
But Patty, you don't have any contracts with ambulance services. They're all independent, aren't they?
Correct. So it's a third party, United Concierge Medicine, who is partnering with all of the local ambulance companies. So that's why we,
Yeah, it's not fully baked.
it's not fully baked. I don't have all the nuanced details, but it's certainly something that has been rolling out in various markets.
Okay.
As well as in-home lab services. So there's there's 3 different things we're working on to do services at home or to avoid high cost services and direct people to the appropriate site of care. So we have appropriate utilization and not overutilization. As soon as we have more details and it's officially filed, we'll share that with you for sure, but it's in the same vein, which is why I think that
We're not being complacent about the trend, is what I'm trying to drive home. We
it's
see
not unique just to you, unfortunately.
So a couple comments before we move on from this slide. I also did want to point out that in looking at the population data, we saw that 24% of members don't have a primary care physician. So that can be another contributor to ER and urgent care spend, really. You know, if you're not being regularly monitored, if you have a chronic condition that isn't being treated on a regular basis, you're more apt, to go to the ER, go to urgent care. So as far as the education piece is concerned, that's, another area that we want to make sure we focus on with preventive care, screenings, regular annual physicals.
That's also a
shortage
market
of
issue.
primary-
A lot of people can't get a primary care physician.
Right.
It's like
Yep.
2 years.
That's true. Yeah. Where we are too in the Capital District, it's hard to get a provider that's accepting new patients. So that's a challenge of itself, unfortunately. And then I also would like, go ahead.
No, I was just gonna say, you're also starting to see a lot of virtual options. Partially COVID pushed us into that with people not, going anywhere and offices not being opened. But you're now seeing traditional providers that are part of our standard network also start to take virtual or telehealth, as we call them, appointments, because they can see more patients in less period of time. As well as us, behavioral health is an example, but you're seeing us start to expand our network to include other types of virtual providers, including specialists and all sorts of things due to lack of feasibility in getting into providers.
I don't disagree, but I think that at least at my provider, wellness visits are in person. Other visits are by telemedicine, but wellness visits are in person. But they've limited the number of wellness visits they do to 1.5 days a week. So the other 3.5 to 4 days are people walking through with sick visits. Yeah, but that's the only way they can make it work for them, is to limit the number of wellness visits. Because they have to do all the lab work and everything too with the wellness visits.
So I know there was a nursing shortage. There's a doctor shortage.
Oh,
now?
yeah.
They're just not going into the
Providers,
field anymore?
period. Yeah, providers, period. They can't afford to, right? So they're coming out of college with a ridiculous amount of debt and finding a job, and it's in their lifetime. They won't pay off those
It's also
college
a lifestyle
expenses,
issue.
unfortunately.
They don't want, the new doctors coming out of school now want to work 9 to 4, 9 to 5.
I have friends
They
that
don't
are in
wanna
the
do that.
field and they didn't, orthopedists who said, I don't want to work weekends and nights.
Yeah.
So he went into pain management. It's like a Monday to Friday and
Yep.
he's out. He's done.
Yeah.
Look how many doctors applied for public health.
Right.
Right.
Which you completely
So
walked
it's
away
actually
from.
an awful
Which is why you're also seeing lower, I don't want to say lower level of care, but the credentials, right? You're seeing a lot more NPs and PAs practicing because that's who they can recruit. So yeah, it's a national shortage. I think initially saw the biggest hit in behavioral health, but we're seeing it across all practices now. And office staff, nursing, everything.
It's terrible.
It's not just the providers, yeah.
So Heather, if you want to chime in at this point, I did want on this topic of ER use, our care management team has implemented a unique outreach approach to try to help address some of the things we've been talking about. So Heather, if you want to come off mute and let us know about that initiative.
Thank you, Erin. Hello, everyone. One of our initiatives in case management is to identify members who have had more than 2 emergency room visits in the prior year and no PCP claims on file. During these reviews, we looked at reasons why people sought ER care. And the purpose of this was to see whether members who were using the ER were doing so for true emergencies, or if their care needs could have been met by going to a PCP or urgent care. For those who did not have a PCP, we assisted those members we contacted in getting established with a PCP and provided education on when to call the doctor versus when to seek urgent care or emergency room care. We are continuing this effort in 2023. For the year 2021, there were 42 Columbia County members that were on the ER list. The highest number of ED visits for an individual member was 5 for the year. We had successful contact with 37 of the 42 members identified. 29 were connected with a primary care provider with verified claims for those visits in 2022. 14 of those members had no emergency room visits in 2022. And I don't know if you're familiar with our hospital to home program, but we had 7 of your members met at bedside for hospital to home support during their hospital stay. So, and as your dedicated case manager, I'm able to assist members in navigating the healthcare system, gain access to resources, assist in coordinating care, understanding plans of care, and provide support in managing acute and chronic conditions.
So I'm sorry, I'm unfamiliar with hospital to home. Is that like a visiting nurse or is it more involved?
Those are we have nurses, social workers, behavioral health employees who are part of our care management department who are actually on site at some of our local hospitals. We go to the bedside, we meet with our members to make sure that everything is going as planned as far as their hospital stay, address any concerns that they may have, assist with the discharge planning to be sure it's a safe plan for the member to return home or coordinate getting them to a rehab if needed. And then we do follow up telephonically as well once the member has been discharged back to home to provide support, just to make sure that they're able to access, the medications that they need. We will help to schedule any follow-up visits that are necessary, call their doctor's offices if there are any concerns about plans of care.
You can arrange for transportation, meals, those types of things. So basically,
Absolutely.
wanting to break down the barriers to making sure they have a successful recovery from whatever their inpatient stay is, and that they and their family members truly understand their benefits, how they work, and that we can connect them with whatever resources they might need.
That's great based on what CMH told us. They couldn't get people out in order, not being able to get people out the back door made it difficult to get people in the front door. So yeah, it's good. So it's really an expediting process to make sure that people have access and move efficiently through the process.
Yeah, and that they understand their benefits, right? We've had, this came about from somebody, I think our CEO actually, having a poor experience inpatient, right? And he's a cardiologist by trade, and he's just like, this is terrible. Nobody wants to be in the hospital. And we need to make, it's confusing. They're not explaining things in a way that the patient can understand. And so we really need to dig in and do that. And so we're not in every hospital, so I'll share that with you. But we are, working at the highest levels to work with whatever hospitals are willing to allow us in to do that. And also based on volume, right, of patients, CHP patients that are in the hospital.
The other key goal of hospital home is readmission avoidance, because if a member has everything they need when they leave the hospital, they're less likely to go back in. And there was a heartfelt story that we got from a member that there was a member that kept going into the hospital and then leaving AMA and going home and then going back in and then going home. And we met the member bedside and found out it was because the member had a cat at home and had no one to take care of the cat. So if someone could take care of the cat, she would stay, finish her course of treatment, and not go home. And something so simple that was just a bedside
So you
conversation.
put the cat down.
I think that I want to say
we found a way
to
feed the cat.
To feed the cat.
That's the solution.
But like just simple barriers to care that you might not get unless you're having a one-on-one conversation. And that was such a simple, inexpensive fix to keep the member where they needed to be, so they didn't keep leaving against medical advice.
So the hospitals that our stakeholders use, how many of those have that option?
Albany Med has it.
St. Peter's.
Albany Med and St. Peter's both have it.
And then we have.
Saratoga Hospital and Ellis have it, but I don't see them on the
Glens
list. Columbia Memorial is not fully on board, but I do believe there's a virtual component of hospital home in Columbia. Glens Falls. But Albany Med, you're top.
Heather, you can correct us if we're wrong.
Yeah.
You're not wrong.
Okay.
I would think it's.
We also have Samaritan in there too. We have staff embedded at Samaritan.
Would think because CMH is a part of Albany Med that it would pull it, that at some point it would extend to CMH,
We
right?
sure hope so.
Heather, are we virtual with Columbia Memorial yet?
Yes, I believe so. There are calls being made to members. Post discharge.
Any other questions or comments on this? I'm going to move on if not, since we have limited time. Okay, keep rolling. So this slide is showing you the top 10 telehealth categories. Utilization, as far as claimants are concerned, are down a bit, but visits were up. You can see that behavioral health is pretty prevalent in the categories. There's some medical mixed in there as well. Really what I take from this, telehealth is obviously more adopted now than it has been in the past since COVID. There is a big need for behavioral health provider options. In-person visits are near impossible to get without a really long wait time. So I do think that considering, potentially another option for Columbia County members like our Doctor on Demand might be something we want to talk about. Doctor on Demand offers medical visits and behavioral health visits. So you kind of have the dual purpose there. So people can use that service and not go to the ER and urgent care for a medical need. They also can use it for a pressing behavioral health need. So that's just something I wanted to float out there. I know we've touched on it in the past, but just the potential area of opportunity.
Aaron, could you have a breakdown on dependents versus contract holders?
I don't in this slide, but I can definitely send that as a follow-up.
Not a huge, I was just, I know we've been hearing a lot about young people having a lot more stress, anxiety, depression, and just wanting to see how it's affecting our population.
That's a very valid point. I can take that as a follow-up for sure. Any other questions on this slide or comments? Okay, I'm going to go on to just an overview of lab and radiology spend next then. So for lab, we see a slight increase in cost despite a decrease in utilization, mostly due to the paid amount and the non-preferred labs being up. I do see that a larger percentage of the population are going to preferred labs, which is a good thing, as the cost per visit is lower at preferred labs. So that's what we want to see. We want to see more going to preferred. Similar case for radiology. There's a decrease in spend and utilization across the board, but we have more people going to the preferred versus not preferred.
How do we find the preferred labs so that we can educate with that?
And our Find It app.
On the Find It app?
And that's another, marketing piece that we could create. We have one that already exists that we use for all groups, but we can customize it too to tailor it to your population.
And in a nutshell, though, what is it? It's LabCorp and
LabCorp, yeah.
Yeah.
So were the 2021 numbers adjusted for COVID? Because I would have thought there'd been a lot of lab work associated with COVID.
Yes, so there were the COVID numbers for 2021. There were a lot more lab visits and tests in comparison to 2022. Costs wise, though, there were actually quite a bit of costs in 2022, and that was because of some inpatient admissions.
There was a slight decrease, so you went from 1,008 to 1,023.
Lori, Michael, I was wondering if you want to roll out a whole did you know campaign, like using your benefits wisely. And day one is, did you know there's all these urgent cares? And day two is, did you know CPHP has preferred lab? And here's the locations in your area. And because it's going to come up again on the next slide.
I guess I always assume that if I go to a provider who's part of the network, they're gonna send me to a lab that's part of the same network.
So CDPHP has in-network labs, which are the majority of the labs in the region, but we also have preferred arrangement with LabCorp. And then all of your claims at LabCorp pay zero, they capitate. And on the back end, you're paying $4.34, I believe, PM for those claims to pay zero.
But not every doctor necessarily has a relationship with LabCorp.
Correct. So there's some member education to say, wait, I do it myself because I go to CCP and my doctor wants to send me to LabCare, not to be confused with LabCorp, but I don't go to LabCare. I take my script and I go to LabCorp because I know they're CDPHP preferred and it's less expensive for the plan. And I do right by CDPHP and try to lower expenses for the plan, but that's the education. But did you know?
CMH is also participating, isn't it? It's not also preferred. So I'm gonna guess most people go to CMH.
CMH likely has a partnership with LabCorp because I know Albany Medical Center does. But I can look into that because I'm not entirely sure. They might have LabCorp on site.
They go up here, or they
I mean, you have pretty good utilization of preferred lab, but not what you're seeing. You're seeing some leak out. But let me check on CMH and
So just
their
to
lab
understand,
vendors.
It's about 50-50, right?
the employee can still go to the other one, it's just we're gonna pay more.
Yes.
Right.
So we really want to, we really just want to
Gotta drive your
advertise that we have preferred. Okay.
Yes.
Right, so we need to get into out-of-state retirees too,
Yeah, right.
that are on the plans. So,
And
Yeah, that's a
LabCorp is
good idea.
everywhere.
Yeah.
Yeah.
Right.
It's definitely something that you need education on. Before coming to CDPHP, I don't think I ever even looked at the lab name I was going to. I mean, it's not inherent to members, so it's something we have to tell people.
Well, or you decide where's the closest lab and they would send you down the hall.
Right.
Exactly. Yeah.
Right, because we have St. Peter's down here and they do their own lab work.
Right.
Yeah, so that's not part.
The other incentive for
That
preferred
makes
lab or
sense.
LabCorp is there's no member cost share. It's reduced cost for you, it's reduced
Right.
cost for the member to drive utilization to LabCorp.
Especially with premium equivalents for an ASL.
Yes.
Okay, well, that's pretty simple. We should.
So next is, I heard someone.
You're okay.
You're okay.
Okay, I can't tell exactly. There's a little
Yeah.
bit. So next is a behavioral health substance use utilization. Costs are up, utilization is up. Of note, the inpatient has more claimants, more visits, longer inpatient stays as well. And I did ask Amanda just to kind of take a look at the inpatient claimants just to see, did they have engagement with our case management team? What other information do we know about these members? So I'm going to have her speak to that now.
Hi, everyone. So along with Heather, we also have a dedicated outpatient care management program specifically for behavioral health. So what they do is not only connect members who are looking for services, but they also reach out to all members who've had inpatient stays, no matter what hospital, in network, out of network, any of that, any hospital really. So I took a look at some of these claimants, and a couple of them have termed, so we won't expect some costs going forward, but we were able to, well, unfortunately with this group, there is a high amount of unable to contact, just the nature of the illness. So we do make every effort to try to get in contact with them, or if we have a release of information on file, we try to get a hold of those folks as well to try to assist the member. We were able to successfully, out of this list, successfully contact uh, uh, 6 of the members, I'm sorry, 6 of the members. We made sure that they were engaged with outpatient services. 2 of these members we engaged with throughout pretty much all of 22, on and off through different hospital stays, just provided support. Another one of these members was a minor, and we worked with mom pretty closely. The mental health component was taken care of after one hospital stay. Follow-ups were all set. She had medications, but there were some questions about some medical needs of the member. So we were able to then transfer over to the medical side of case management and assist with that as well. But any other detailed questions, we can definitely circle back to those.
Amanda, when you said you had 6 successful reaches, you're talking about the folks that were inpatient for mental health and substance use.
Yep.
Okay. Just talking about the.
That's 6 out of 7.
So 6 out of 7?
Yes.
Yes.
Those are the ones I asked her to look at. I didn't ask her to look at anything other than inpatient.
Yeah, perfect. Thank you.
Yeah.
That's great.
Yeah.
Any questions, comments on this slide outside of the inpatient stays? I mean, clearly there's a need. We know that. Nope. Okay. Moving on to the top 10 high cost claimants. So number 1 here, of course, is our $1.2 million claimant. There were a number of factors and medical issues that were treated for this individual, primarily liver transplant and then many post-op complications. And I am going to pass to Heather shortly to provide some other detailed information, but I just want to talk through a couple more of these claimants. The second one on here is a patient with Crohn's and ulcerative colitis and on a high dollar medication, Stelara. So that one will definitely see continued costs there. The subscriber, the third one on the list, is a spinal surgery. So it was a successful surgery, although high dollar. We shouldn't see continued costs for that one. And then the fourth one on here was a cervical fracture and brain injury, and then other complications after that, which ultimately ended in the member unfortunately passing away last summer. But to jump back up to our number 1 claimant, Heather, are you able just to share some other details just about the condition and what drove some of the costs and if there's going to be continuing costs?
Of course. Thank you. So this gentleman had a few admissions in the early part of 2022 for cirrhosis of the liver. He ended up going to Westchester Medical Center in early March and received a liver transplant on the 20th of March, 2022. During that stay, he did develop complications. He required dialysis. They found that he had a non-traumatic bleed in his brain. After he stabilized and got discharged home, he was readmitted an additional 6 times for worsening of his condition. He ended up having infection inside of his abdomen. He was beginning to have convulsions, seizures, and brain swelling as well. It seems that he has stabilized. Our care management department was in touch with he and his wife, and they've been able to assist. And we last had a touch base with him back in January with our registered nurse care manager who was working with him. So I would anticipate, because he is a liver transplant. He has had many complications. The admissions have diminished, though. He hasn't had any recent ones. So since January, and he's maintaining follow-up care with all of his specialists and primary care provider as well.
Thank you.
You're welcome.
Any questions from the room on this one?
On the high cost claimants, is there a way to integrate what stop loss has paid so that we get one report that shows these are the high cost claimants, this is how much went to stop loss? And these are the ones that we've applied for, but we haven't gotten yet, or something of that sort?
Yeah, I can get you a breakdown. I do have some information from Joanne that I'm going to send. So I can give you that picture.
Anything over that, we get like
You say it's 100?
300.
300.
Okay.
That one's January. Just under. That's all right. Don't worry about it.
We can do the next.
Okay. I can hear some of what you're saying, but I can't hear all of it. So, all right.
We do have a summary that Joanne puts together that we can send you that will show all of the reimbursements for the 2022 time period. So you could take this information and deduct the stop loss reimbursement.
Does that names or does it connect the different?
It will connect. We
Okay.
can make sure it connects the dots.
All right.
Yeah. That's what I plan to send regardless.
Yeah. Thanks, Sarah.
Cool. Okay, so before we move on from this high cost claimant slide, Heather, do you have a case study that you could speak to?
I do.
Okay.
We had a referral for a 68-year-old male back in August of 2022 who had a new diagnosis of heart failure. So our care management nurse reached out to the member, spoke with his wife, who gave some medical background. Part of our initial conversations are to assess what it is, what type of equipment they may have in the home to be able to manage their condition. So they were able to verify that he had a blood pressure cuff and a scale at home, was monitoring himself on a daily basis. The wife seemed to be more concerned that he wasn't taking his health seriously. Our care manager suggested he speak with his cardiologist about cardiac rehab to see if that would be beneficial or not. And the wife was in agreement. And the day before his cardiology appointment, our care manager reached out to the cardiology office and spoke with the nurse for the doctor and confirmed that cardiac rehab would be discussed during the appointment. The case manager confirmed that the member had the equipment to engage in cardiac rehab, and the wife was still concerned that he wasn't going to be able to follow through, and explained she had been looking through old photos and noticed how much he had aged in such a short period of time. Our care manager offered her support and empathy and suggested showing the photos to the member in an effort to get him to go along with making the lifestyle changes that he needed to. The care manager also encouraged reconnecting with their primary care provider because the member hadn't had an appointment in over a year. And just this past September, the member did start virtual cardiac rehab and had some technology issues with it. The company, if you're not familiar with it, that CDPHP has partnered with is called Moving Analytics. So Moving provides virtual cardiac rehab experience for people who are like mild to moderate cardiac risk and don't require going to a facility. So we were able to connect the member and his wife to the Move-In program and their technology support to get him up and running to participate in the cardiac rehab. And in October, the care manager continued to work with the wife. The member was continuing with this cardiac rehab and reported feeling better. There was a concern prior to the engagement that he may need a heart transplant in the future due to his heart failure. And our case manager just provided more guidance to the member and his wife on speaking with their provider. We were able to confirm that he did see his primary care for the first time in over a year, and that was back in the fall. And in November, the wife was connected with our member services department for benefit questions about exercise equipment. Move-In does provide some equipment, but most of it is needed from the member, either by going to a gym or buying your own equipment. And then in December, he graduated from the Move-In cardiac rehab program, was feeling good, has improved cardiac function, no longer concerned about needing a heart transplant. He maintains regular follow-up with his specialists and primary care as needed. And they even ordered an elliptical machine so that the member could continue to exercise during the cold winter months. And he has had no hospitalizations since his care management engagement. And he, as I said before, is continuing to follow up with his cardiologist and primary care provider.
That's great.
They saved us $1 million.
I was just Thank you, Heather.
You're welcome.
You can take the rest of the day off.
Thank you.
Thanks, Heather.
Thank you.
So to wrap up 2022, I'm just going to quickly talk through this wellness slide that gives an overview of the preventive care. So you can see that there's a decrease across the board with routine physicals. As I now mentioned a couple of times, we have a significant portion of members that don't have a primary care provider at all. So that obviously contributes to this number. And then I think, with COVID, people got away from doing routine physicals, and we need to kind of just get back into the swing of things. Reminders always help. As you see on the below, there's screenings listed here. So we have, the benchmark rated against the Columbia County's percentages. Breast cancer is above benchmarks. That's great. Cervical cancer screenings are a bit low, as are the colorectal cancer screenings. You'll see that there's no benchmark next to colorectal, and that's because we don't have an accurate benchmark yet for data because the age group expanded. So it used to be just 50 plus, now it's 45 to 49. So we'll have that towards the end of this year. We'll have a benchmark for that. But really my takeaway from this slide is, we talk about total cost of care and comprehensive health care for people, and preventive measures are our foundation for, good health and lower expenditures. So it just has to be a big focus area. Questions on this slide?
So again, I feel we tied this in with our education piece. We've talked about how prior to COVID, we had a wellness fair. And that was something that, was one event that we had in one building, and people came down, and that was wonderful. People came. But when you look at the numbers of individuals, not. So this year, our focus will be wellness fairs, mobile, and going out. So rather than having that to, we can still plan one where we have the vendors come in, but I think this is going to be more about having, our staff going out and bringing all the forms and all the things to them to talk about. You can see the numbers of staff that have even done the reimbursement for their minor wellness points program that we run. To have these screens done, you get so many points. To bring in something for like a Weight Watchers type item or a gym membership, you get so many points. That has plummeted because people were not doing what they needed to do during COVID. So we just had a wellness meeting the other day to talk about kicking this back off again. We do have an LPN in the county who's now going to be getting involved in this project as well. So I think it's a good opportunity for us to kind of re-educate and start a new initiative.
That's great. Please let us know how we can help. We do have a lot of resources and are more than happy to help with the wellness committee.
I'm sorry, but who is the CDPHP rep who, there's an individual that was involved with, is it Allison?
Allison Reinhardt.
Yes, thank you. Okay. So we'll be getting, Holly and I'll be getting back in touch with her to have her come back in again as far as this initiative, because we're going to have to assign some new committee members too, since we've had movement and things like that. So it's a good time for rebirth.
Jim was
wonderful. Yes. Thank you. Yes.
Okay. Awesome. So now I'm going to shift gears to pharmacy and pass to Lori.
Hi, everyone. My first chance to meet with the entire group now that you're a new pharmacy client of ours, and we're happy to have you. As you know, we moved to a new PDM in 2023, and while there's always going to be some learning to dance with your new partner along the way, we are very pleased. The promise of transparency and pricing is coming to fruition. We are absolutely seeing realized savings, excuse me. And, you know, we need more experience with your claims and have exact, you know, information on previous experience. But when we tried to do a modified assessment, it does look like we are helping reduce your overall spend on a relative claim to claim, which is great. Let's see a few other points I wanted to make. Another important thing that we enjoy by having the whole member is that, you know, we keep the pharmacy piece for utilization management in-house. We have a team of clinical pharmacists who work very closely with our behavioral and medical case managers. So that's a synergy, and we're all used to be in the building all together, but we're all, you know, a team's text away, if you will, in addition to in-house medical directors. So that really helps with our ability to have true visibility across the medical drug benefit, which we previously were managing for you, but now also the prescription side. So having all of the pieces of information closer to real time helps the case managers, helps the pharmacists, helps the medical directors to really make sure we're doing the best by the way of the members as far as access and needs, but also helping make sure that we're doing the best we can with respect to your plan. And as Patty noted before, we always are focused on the total cost of care model in general. Sometimes you need to spend more in Part A to reduce overall spend. Yes. Can I answer a question?
I was just going to say, when can we get a report to see what we are spending? Well, how much time do we need? Is 6 months enough? Get it?
Yeah, so when it comes to the rebate data, we won't, so we could give you, you know, gross spend, but we won't have rebate detail towards till the end of June. And then we'll be very happy to start. So we can do it in 2 steps, but I think it's misleading if you look at gross spend without having the rebate impact, because there is quite a bit of rebate value that should be coming back to you.
I think we did some preliminary, right? When we were kind of problem solving, if you will, we looked at some preliminary data. So if that hasn't made its way to you, I'll go ahead and send it
No,
over.
probably did. We looked at an awful lot of stuff.
Yeah.
We were going through that.
Yeah, but it showed kind of savings to date, and then if we moved forward, the RX for less additional potential savings, and we gave an estimate.
Just to remind everyone, we switched over to Capital RX via CBHP because they promised us
How can we forget?
approximately $1 million in savings compared to what our you know, former PDM was. And so, you know, we're eager to see that that's playing out, at least to some degree. Obviously, you can never have apples to apples in this business, but you can see trends. So.
Yeah, and I want to say we saw like an 8% reduction.
Yeah, it was
in the,
pretty
in the first
significant.
quarter, but when we round out another quarter, I think we should do the analysis again.
Yeah, the other thing that CDPHP was successful in doing is we did our own specialty pharmacy RFP for 2023, and we really did gain some impressive improvements in pricing. So some of the biggest drugs, Humira, Stelara, Enbrel, probably drug names you know and recognize are usually at the top of the spend list. We gained multiple points in pricing starting in 2023. So that is something, and I did try to do a peek and do a comparison based on previous claim information that you had provided. And in some cases, and again, not having the whole apples to apples, but it looks like in some cases we're improving your pricing on some of those drugs 5%, 7%. So again, that's gross. That doesn't yet incorporate the rebates. And then the coupon program, the way that Capital RX operates that program, you know, they do the best that they can to try to get every dime during the plan year from the coupon program. And so we're working very closely with Capital RX and with the specialty pharmacies to make sure that we're smoothing out operations, because as a new group coming on, we don't have all of the history of when the coupons were started, that kind of thing. But we have also at CDPHP we have a team of specialty care pharmacist case managers, and they specifically focus on specialty drugs. They engage with members, they engage with providers, and the goals are making sure that there's appropriate access and timeliness for, pardon me, my phone just started ringing arbitrarily, timeliness in access, making sure that they're tolerating it, making sure there's efficiency in dispensing. So if somebody was, for example, on a drug like Humira or Enbrel and they were hospitalized, we'll just say with COVID as an easy example, they're probably going to hold those drugs during that stay. But the specialty pharmacies may not have that inside information. They may continue to try to fill. And, we try to mitigate that by staying on top of that. We have insight into when people are hospitalized. And again, we work out with our case managers, any hospital at home programs when they're involved to try to make sure that we're paying attention to this. And I will say, and we just got a report today on where the coupon program has been performing for year to date through April. And you're right now, it looks like you've gained quite a bit of value. So one of the things that Capital RX does is even an improvement based compared to our previous program, in addition to trying to get every dime available as best they can, is that they have relationships with more than just a single specialty pharmacy. They have an entire rep network, and we also have brought in a couple other local specialty pharmacy providers. So some of the drugs that are called limited distribution, that say one of the national pharmacy chains may not have access to, if they don't have access to it and they're the only ones in the coupon program, you don't get any value. I did a comparison and saw that there were a couple people that you have that are on a couple of those limited distribution drugs that didn't appear to be on the claim for your coupon program in 2022, but there is value coming in 2023 for those two folks because Capital RX has this wrap network on those for those extra special limited distribution specialty drugs. So overall, we're very pleased. They're a great partner. One of the things we really liked was their platform. It's cloud-based, and a lot of the big three PBMs, they're on old archaic, DOS-based screens. I don't know what kind of programming, and they've had to just continually Band-Aid. And so making changes can sometimes be cumbersome and risk-prone. Whereas we've had conversations, Capital RX, and this isn't across the board, but they've been able to fix things in an hour or change things in an hour, not always fix if we say, hey, can you do this? So overall, it's we're very pleased with this partnership, and we're very pleased to be a partner with you in this regard. And please feel free anytime if you have any questions at all on the prescription benefit. I'm sure you would anyway, but reach out to Erin or Diane, and they know how to find us. And we'll get right back to you.
I think we can give another savings analysis after we have another quarter under our belt, but Patty just pulled up the email. It was about 80K, 8.5% reduction. And then if you added in RX Plus, which you chose to, we saw 30K in savings. Plus there's no admin fees under CDPHP. I'm not sure that could be about your payment or not. So
that's for the first quarter?
That's just for the first quarter.
So that's 100,000 a quarter. If we stay on track, it would be 400,000 for the year.
And that's gross spend with no rebates baked into it. So we're on track for some good savings, but it's too early to tell exactly what the end result will be.
But not a million.
Not a million.
Not a million.
Well, you have the coupon rebate.
Yeah, you have the coupon program and the rebates. Both not factored into that.
I thought you just talked about 200,000 in rebates. 800 plus 200.
No,
Who said 200,000?
it's 78K and 29K.
Okay.
Those are just direct savings.
Those are direct savings.
Both are direct.
Yeah, that doesn't.
Those are direct
Not-
savings that you're already experiencing.
Right. That doesn't include rebates, coupon programming, or the saved admin fees by not having to pay a
Right.
separate PBM.
Right. The other thing is usually in an annual review, when a client has medical and pharmacy with CDPHP, we offer the pharmacy review. You're new, normally wouldn't speak to pharmacy, but we felt as though we had to.
We don't
this
feel
year.
good.
Right.
We're confused.
And we wanted to introduce you to Lori because she is our SVP of clinical pharmacy. So her team is the one doing the PAs and talking to members. She is on our pharmacy and therapeutics committee, writing our formulary and kind of the clinical brain behind the pharmacy operation at CDPHP. So we thought it was important that you name and face her because you're going to hear her name a lot as we continue our partnership.
I wanted to, just, I guess we're getting at the end. So Lori pointed out to me the other day that when we first went self-insured, we paid the prior year 8.2 million roughly, and it looks like we just paid 8.2 million. So in the 5 years or so, we basically kept it flat.
That's pretty amazing.
Yeah.
Yeah, which is practically unheard of. So we've been doing the right thing. It's not easy to keep costs down in this area.
We're not done yet, Steve.
Okay, you get me better and I'll tell you're done. I'm not even on your plan. Is that it?
I know we're at time, so I just have,
opportunities.
yeah, just our last slide, but I've already really talked through most of this. So, preventive care campaign, appropriate ER use, overall, how to best use your medical plan. I think we all agree is something we want to focus on. And then leveraging our workplace health resources. So Allison, who can help with your wellness committee in those initiatives. So this is what I've come up with for now. Obviously the list can grow.
I also wonder if there's opportunity to link your new LPN with someone clinical at CDPHP. So let's keep that in the back of our mind.
Yeah, she serves a particular purpose for the
Okay.
county though, so, but we could certainly take a look. at
If
that.
there's
Thank you.
opportunity,
Yeah, no,
yeah.
I appreciate that.
She might even have recommendations just from being so close to your population.
Right.
Yeah, for Allison.
So that's what I have. I didn't want to go over time. But if there are questions and we can go over time, then please let me know.
We didn't have much in it.
Connie, I got a question. Can we bring that van down here with the PCP in it and just start shoving our members in?
Feel like
You
that's
guys
what
might
we
be able
only
to
get.
work your magic with
When
the
we get that
CCP
one.
providers and
Yeah.
chef.
I mean, we can-
We had a great time.
Yeah, people like the van.
Yeah.
Yeah, Van will be back next week. So
Yeah.
You saw the tips.
How many have we done?
We've done 2 days this week. Okay. And then we put
Yeah,
Thursday for next week. I just want to thank you again for all
Oh,
of
of
your.
course. It's been great.
And, yeah, Lori certainly came back, very intimidated with some positive attitude from some people.
Well, let me say
that
thank
were
you to
having
Lori too,
problems.
because she's been a
Yeah,
constant
she's
through all of
amazing.
it,
She's-
so.
Yeah, there should be no
Amazing.
problem with it for sure.
Well, and at one point yesterday, I think there were 4 CDPHP people yesterday, and all 4 of us had someone, and Lori's like, I'll take you. I'll show you what they're
You don't
doing.
need anything.
It's like,
Get out of here.
she could do it. She could do it on her own, but we're happy to
Just
support.
so the committee can hear that, there's been some very favorable communication from employees about, things that were problems for them before and meeting with our CDPHP reps and their professionals that were able to assist them. So,
Great.
it's been a very nice initiative. So thank
I'm
you.
glad. Good.
Yeah, I want to thank you guys for hanging in there during a very difficult
Our job.
transition here. It was, you didn't wash your hands at all. You jumped right in. It was not easy. We certainly blamed you every time we could. So,
You have the right to do
We
so.
fixed it.
but you were willing to actually fix what was wrong, and I think it's for the most part fixed. So, well done. There's always problems, just a matter of how you're going to handle them. And you guys, we're afraid to get your hands dirty. So,
And we got something out of it. We get to get in front of members, which is really what we like to focus on doing. So we're all about it.
Thank you.
Thanks for having us. Of course.
Thank you.
All right, of course.
Thank you.
thanks, Aaron.
okay.
Thanks, Aaron. Feet
So-
up, Aaron. Feet up, Aaron.
Bye.
Thank you. Thank you, everybody.
Bye.
Bye.
Motion to adjourn?
She's very technical.
I'll make that motion. We have a motion. Art, you want to second the motion?
Second.
Brenda beat you.
Too late, Art.
There's Art's nose.
All in favor?
There you go.
Aye.
Thank you.
Thank you.
I'd like to call the Finance Committee meeting to order. We're going to get started with resolution number 1. Authorization for the Department of Human Services to abolish a now vacant 1.0 PTE grade 19B.
Move it. Second.
Motion and second, all in favor?
Aye.
Opposed? Carried. Resolution number 2. Authorization to award Twin County Recovery Services, substance abuse.
Second.
Motion and second, all in favor?
Aye.
Opposed? Carried. Number 3, authorization for the Health Department to fill 1 public health technician.
Move it. Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Number 4, authorization for DSS to fill one social service investigator position, grade 12A.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 5, authorization for DSS to fill one senior social
Move it.
welfare.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 6, authorization for OFA to accept an insurance payment related to a vehicle accident.
Move it. Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 7, authorization for OFA to amend the contract with Anytime Home Care, Inc.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried.
So does that mean that program's been really successful and we're adding to the staffing?
They're the only ones that are actually providing it. The other providers aren't providing the service. So the money, we haven't changed the money any. It's just like they're going to get more money because they are doing it.
So we're not actually increasing how much we're offering, we're just shifting it more. Okay, thank you.
Okay, number 8, authorization for
Move it.
OFA.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 9.
Move it.
Can we, before you move this one, can we just, it needs to be cleaned up a little bit. The actual grant amount is 14,280, and I think they rounded up to 15,000, so we just need to clean up. Wherever it says 15 needs to be 14,280, and it's this one and the next one.
I'll move it with that amendment.
Okay.
Second.
We have a motion and a second. All in favor?
Aye.
Opposed? Carried. Number 10.
This is not to exceed $15,000.
Right.
And it's actually
And actually, in the text, it says 14.
Yeah, right over there.
Yeah, they went back and forth.
Yeah, I think, yeah.
I'll move it with the amount amended.
All numbers are rounded off.
Okay, we have a motion. We have a second.
Yes.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 11, authorization for the district attorney to upgrade the salary of assistant district attorney.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried.
And just to make sure I understand that, we're not shifting at all from what we set up. It was just that she's kind of not in the rating that she should be.
Yeah, she got moved
Adjusting
up.
her.
And then
We are changing supervisor.
But all of the same tiers, nothing's getting.
No, you're changing tiers. Say, we were sure about.
Yes, that was good.
I think the request was to go outside the tiers just a little bit, but.
No,
We
we
just did so.
stayed with it. Okay, number 12.
Move it. Second.
Motion is second. All in favor?
Aye.
Opposed? Carried. Number 13, authorization to fill a vacant.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 14.
Move
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 15, authorization to purchase 1 patrol vehicles and related equipment and to amend the 2022
I'll move it.
adopted budget.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 16, authorization to update agreement with Consolidated Communications.
Move it.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 17, authorization to amend the 2023 adopted budget for the BOA for unused
Move
grant
it.
funds.
Second.
Motion and a second. All in favor?
Aye.
Opposed? Carried. Number 18, authorization for veterans to contract with Breezy Lawn Farm for horse farm therapy.
Move it. Second.
Motion in a second. All in favor?
Aye.
Opposed? Carried. Number 19, authorization for highway to sell at auction surplus.
Move it. Second.
Motion in a second. All in favor?
Aye.
Opposed? Carried. This is Ron's $357 chase. Resolution number 20, authorization for highway to revise resolution 438-2022.
Second.
Motion in a second. All in favor?
Aye.
Opposed? Carried. Resolution number 21, authorization for the chairman of the Board of Supervisors to enter into an agreement with Casella
Move
Recycling.
it. Second.
Motion in a second. All in favor?
Aye.
Opposed? Carried. Number 22, authorization for the chairman of the Board of Supervisors to enter into an agreement with Paradigm Software for updated training on the scale software not to exceed $900.
Move it. Second.
Motion in a second. All in favor?
Aye.
Opposed? Carried. Authorization number 23, authorization to transfer funds for the purchase of county garbage bags.
Move it. Second.
Motion and second, all in favor?
Aye.
Opposed? Carried. Number 24, authorization for facilities to fill one vacant full-time laborer position. Any backfills created there?
Move it.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Number 25, authorization for facilities to fill one vacant
Move it.
part-time.
Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Number 26, authorization or appointment of Peggy Moon to serve as a Columbia County Business Rep to the Columbia Green Workforce Development Board.
Move it.
Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Number 27, authorization to submit a 2023 application for New York State CDBG Micro Enterprise Funds.
Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Number 28, authorization to award the bid for meat and meat products.
Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Resolution number 29, authorization to award the bid for canned frozen foods.
Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Number 30, authorization to award the bid for ULS diesel fuel.
Move it.
Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Number 31, authorization to award the bid for unleaded regular.
Move it. Second.
Motion in the second, all in favor?
Aye.
Opposed? Carried. Resolution number 32, authorization to award the bid for liquid propane.
Move it.
Second. Motion in the second, all in favor?
Aye.
Opposed? Carried. He's had that a long time.
Yeah, I was just gonna say, I'm surprised to switch that one again.
Okay. Next one, authorization to adopt and issue a home rule request to the New York State Legislature with respect to the Senate Bill S 6807 and Assembly Bill number A 5866A.
Move it.
Second.
Motion in a second, all in favor?
Aye.
Opposed? Carried.
Yeah.
Okay, the next one.
Yeah.
Authorization to adopt and issue a home rule request to the New York State Legislature with respect.
Second.
Motion in a second, all in favor?
Aye.
Opposed? Carried.
Can I ask two questions? And this might just be because I wasn't following some of the home committees. The garbage bags. So is that just those small ones or?
No,
I know
that's
those
all
are
of them.
long.
Yeah.
So we are going away from the punch card again?
Yep.
For the bags?
Yeah, a while.
Okay. And I assume communication will go to the town clerk's office?
Yes.
Yes. I mean, the bags work so much better. We talked about it, but it's just a lack of.
We're gonna, lessen them, we're only gonna have 3 different sizes now, you know, but.
But we are keeping that small one that there was
Yeah,
a lot
yeah,
of.
yeah,
back.
that everybody wanted, yeah.
Yeah.
But yeah, we'll have them.
1, 3, and 5, I think.
Yeah,
Was
right.
it $1, $3, and $5.
Okay. And did we ever form the group, and I would be happy to be on it, to really look at, are we subsidizing garbage or are we not? And if we're not, then we need to make sure we're actually charging what we're paying. I know we had that discussion months ago. Before we go into next year's budget season, I'd love to see some sort of analysis. You know, I made this argument before, I pay for my own dumpster. But if my tax dollars are paying for garbage, then I want to take advantage of that. And I actually am not, I don't have a horse in the fight or whatever that's called. I don't care which way we go, but I think you have to go all one way or all the other way. You can't just subsidize it from taxpayers to make it less than it should be.
Well, there's been some discussion on that, right, Ron?
Yeah, there has, yeah.
And
I think a lot of it is, you know, trying to pay for all the capital improvements in the last few years. You know, we didn't do anything for 30 years and then we dumped $3 million into it, you know.
Sure.
And years ago, we used all that revenue to cover the cost of landfill closures and things like that, you know, and we did that. So there's a history of it, but yes, we are looking at that.
Yeah, because like obviously the capital expenses have to get built in. So if every 50 years you need $3 million, then you're going to add on, you know,
So, yeah, I
50
think,
cents to each bag to get to that.
Well, we made that
so.
argument the other night. I mean, we had a request from Habitat, you know, they wanted to provide free service to them because they're a good organization, and they certainly are a good organization. But again, you know, we're already at, you know, a losing end of the battle, and to give them more. We talked about a committee that, you know, the committee just felt like, no, we're trying to cover our costs, you
Well, there's
know.
also a lot of great organizations.
There are, and it's gonna open the door for every
Still want
firehouse.
that.
and-
How much would the bags, you know, off the top of your head? be if we were not to lose?
I'm sorry, if we.
How much more would the bags be if we were to
Break even.
break even?
Well, you have
Oh,
$1 million in tax levy going away. So
right. So it's $1 million.
$1 million.
Yeah.
But do we know that split over how many bags that are bought?
Well, it's not just the bags. I mean, a lot of it is the tipping fees over the scale, you know, stuff like that.
Well, it's pretty easy to do an analysis on that to see how much tipping fees we have and how many bags we sell as an average and then raise it.
If you have 2 million in sales total and you have 3 million in expenses, then it's gonna go up 50%.
Right.
So anyway, I'd be happy to help. I'm not on that committee, so I'm also happy not to
Okay.
help, but I would love to see before we go into the budget season, because it's one thing.
We dug into that a little bit last year in the budget, and we started to break it apart a little bit, remember that?
And I think, and that's, it jogged my memory when I saw
And
that, because I
there's a
think we
couple
talked
other-
about forming a committee and really getting into the details.
Well, I don't think we need a committee. I think we just need to look at the numbers.
Yeah.
I think we,
We're pretty comfortable that somebody has a pretty good idea. I do.
Yeah.
And I know one of the things, we're losing money, but we agreed to stay where we are. But even at that rate, the commercial guys are still going across the Good Van Winkle Bridge because it's still cheaper.
Right.
So how are they doing it? That's the question that probably should be asked.
Yeah.
Well, they go to Canaan too. Everybody runs to Canaan.
Right.
It's way cheaper.
And I think we said we're okay with that. Like, we don't necessarily need people
Fine.
taking our garbage.
Fine, but
Right.
I had said it originally. I don't think we should be subsidizing.
I think there's other discussions that can come out of this as time goes.
Yeah.
Once we get into the
There's a
budget.
lot of
Anyway, that
them.
triggered to me that we had had that conversation maybe 4 or 5 months
Budget
ago.
time
and then
starts pretty soon. so.
Yeah, I think.
all of a sudden you're in budget season again.
Yeah.
and you go, oh, wait.
There are.
Yeah.
I've got one question. Global, who are they? and Where are they at? I got the gas bid.
Global,
Yeah,
they're in Massachusetts. Yeah, they have a state contract.
they're in Massachusetts.
Mhm, yeah, but yeah, they do have a state contract.
No, our fire company tried to deal with them, said it was horrible, so they just went to somebody else.
So it just depends. I mean, the problem is if they're the lowest bidder and I have no documentation on any
Right.
issues, I can't exclude them. So if we have problems with the towns or with the county, it just needs to be documented.
But locally, what we usually just do,
Couple of years.
Yeah.
You know.
I used them in my lab,
when you have, I mean, we've done this before in the town. I mean, if the county picks a vendor and the town can't deal with them because they won't do the billing correctly or something, we just do a resolution to go to another company, you know.
Yeah, you don't have to, like, we add language into our bid.
Best value
The
type
political
situation.
stuff, you know, so you guys can partake, but you're not required to. But at the same time, like, I spoke with, I think it was Hudson last year, with a different vendor. But I was like, if you guys have problems, I just need to know that so I can document it. And then when we go to award the bid, next bid period, I have the documentation showing, hey, I'm not awarding this to you, or I'm.
Yeah.
not
One of my concerns was they're out of
accepting
state, you know? So, you know.
But we do have language in the bid too that
Yeah,
says
you
that they
can
have
go
to
for it.
come in within a certain amount of time if we have an issue. So if they were to ever not do that, I can also use that as grounds to not award that bid or to remove the contract from them and then re-award the next level bidder, which is something that we had to go through with one of the other bids.
Who had it last year?
They ended up with it last year after a
gonna
re-award.
say,
So Main Care had it originally,
Right.
could not uphold the contract terms and therefore Global ended up.
So I thought they were doing okay though, or not? Global.
I have it from the purchasing department.
Did you hear anything,
I
Ron?
haven't heard anything.
Like I said, my local fire company tried to deal with them. I don't deal with them in the town, you know.
No, but I
We
mean,
went to
from
all
Public Works or anything?
No, I haven't heard that.
I know that, Nolan's been there a long time. They've been doing a good job.
Like, yeah, they
Yeah.
won, and I don't even think that their differential has changed in
Yeah.
the last few years.
I know that.
From that perspective. But
They're
yeah,
just charging us so much over
what the,
to be honest with you, I have no idea how they charge.
Well,
They charge it.
it's, yeah, but what's the name of that? It's Opus. It's
Right.
Yeah.
so many cents over
that number.
Do you know what that is?
Same as.
So the differential I
yes.
put in that, but yeah, what we do is we put the bid out and it's based on a differential from Opus. So whatever the
Right.
Opus price times whatever. I
Correct,
don't
but do you know what
remember.
the difference is?
I think for Nolan it was 0.1985. I did put it in the resolution.
Well, I'm sorry, what is that?
0.1985 per gallon.
That's
of
LP,
liquid propane.
yes, LP.
Yeah. For the-
What is 0.19?
Like
So
19
that's
cents.
No, I know. That's
Yeah,
what, 19
that's the-
cents over?
That's it. That's why they always win. I think the other responders were at least in the like
Did
3
you?
0, 3 something like that, but no one does that. point where you're.
Well, what he's doing is using this to keep his numbers.
Yeah, yeah.
I paid 50 over, which is a good price.
Yeah, that's what I'm saying.
For what, I use a lot. but
And
use
I think
20.
he's done a great job.
Yeah, we've never had, I mean,
Yeah,
there was.
been good service.
For years, I always see him.
I know. I should call him. We use it
Yeah,
at the town.
should
and
ask him.
they, I don't use that much volume. I mean, I use a lot for small
Yeah.
business, but
Yeah.
I mean, we use 1,000 gallons a month.
Is there anything else?
Just back to the solid waste comment. I mean, if we know we're subsidizing, which we know what we did last year, $1 million, we know we're subsidizing again. Do we necessarily want to wait until budget time to react to this? Or do we want to start looking at and maybe start introducing additional fees pre-budget? Because I don't want to get to the budget and say, oh, it's last minute. What do we do? I do agree. I don't think we should be subsidizing because I mean, half the county does not use or use private carriers. Like
Yes,
myself.
that was my argument last year.
So I don't think we should be subsidized something that should be a user fee.
Or
So-
maybe do a tiered system. So maybe like June of this year, bring bags up 50%. And then we would also have 6 months or at least 3 months come September of revenue to see, okay, how did that shift?
They did increase the prices.
Yeah, just gonna tell you that, yeah.
But, for a
But it's
dollar
still
bag,
way,
I mean,
it's
we're
like
gonna
you
give
have to
garbage
do
for a dollar bag. I mean, come on, I mean, a dollar.
So
bag
Jim,
is-
can't we just get an
Can you give us
analysis
a
on that? And then we could just look at that and say, yeah. because it's
Are they
great.
tracking the amount that's raised by just the bags themselves?
Yeah.
Yes.
But, and I can tell you that that's not good. I mean, our revenues are not what we've anticipated so far this year. So it's, a lot of it is because of that sticker thing, I think,
Go back to that again, it's still losing.
Yeah, we believe so. That's one of the reasons we're trying to change back to the bags,
Well, and also like recycling. So that's a whole nother, like, are we charging enough for recycling stickers? Because the recycling cost is a different cost. We know what recycling costs and we know what
I think
recycling.
we are gonna have to look at
So
raising
we're
that
gonna have to
the first of the
analyze
year.
it.
We should charge whatever it costs us. We shouldn't make $1.
Well,
I think there's another issue,
Group
because they
together to look at it.
Yeah.
Including Jim and Ron and a few others, because, we can speculate, sit here, but we need to take it.
No, I go over these numbers with Jolene all the time, and it's not.
But there's also a lot going on at.
Why are people getting away with not paying when there's issues at the station?
Keeps the trash off the sides of our roads. Because if you go over a threshold, it's going out the window. And we're picking it up for free and costing us even more. That was one of the.
That's what
theories
used
for-
to happen years ago.
No, we're talking about not tracking
Deputies.
No, this is, it's a different story.
Yeah,
So what they did, Rob, is they were buying, $1 stickers and putting them on a $5 bag. We even found that somebody had learned how to counterfeit the stickers and they were manufacturing them and, they were
Maybe
just
even sell
stickers,
them.
and they
So
were
if somebody
avoiding-
puts a $1 bag on a $5 bag, what happens? It just gets flipped
If
through?
somebody doesn't catch him at the gate and then, then figure it out, then.
Goes through. It's not working.
Well, and that does get fixed moving back to the bags because you can only fit as
It's
much
not
as you can
fixed yet,
fit.
that's why we're still losing numbers.
Right.
Yeah.
That's why we're trying to go back to the But bags. is it, It's one but of is the it things. just the bag? It's gotta be the tipping fee too, right?
Yeah, it
I mean,
is.
tipping fee's gotta be more than the bags, I would think.
We're gonna adjourn
Yeah.
first.
Okay.
Is there anything else? Need a
I'll
motion
make
to
that
adjourn?
motion.
Second.
Motion is second, all in favor?
Aye.
Opposed? Okay.